Hello, my name is Steve LeCroy. I'm the Director of EMS Sales for Mercury Medical. I also provide most of the clinical training here for Mercury and Mercury's customers. I've been a paramedic for a little over 35 years and a respiratory therapist for close to 40. Today's training wanted to cover something that's really basic, but can also be advanced. And that's talking about what you see here. And probably everybody in the room is familiar and has seen this device, our typical bag valve mask. Some call it a CPR bag, but basically a manual resuscitator. The bag that I have here on the screen was developed probably decades ago. I'm thinking 30, 40 years ago, if not longer. And if you look at the size of it, this is about a 1,500, 1,600 cc bag. So why is the bag that size? Well, nobody really came up with a real good reason that I could find out in research why the bag would decide, other than the fact when I first became a respiratory therapist in the 70s, when you were setting tidal volume for a patient on a mechanical ventilator, the volume was somewhere between 10 or 12 mLs per kilogram. So therefore, it kind of made sense that you would have a bag of this size, because the stroke volume is not 15 or 1600, which basically is how much can you get out of it as a stroke volume, but it would be in that range. So that's what we did. We used a lot of volume. We created a lot of issues we know now. So basically what I have here in my hand would be considered, at least in my mind, would be considered an antique. So why would I want to change at this point? Well, let me ask you this. If you had a patient you were putting on a mechanical ventilator, and some of you in the audience may do that, would you put somebody on a ventilator that you didn't have somewhat control of the volume or somewhat control of the pressure? We know about lung protective ventilation when it comes to mechanical ventilation, but shouldn't some of those same theories and strategies also apply to a manual ventilator? So why do we do that? So why do we make those changes? Well, if we look at the standard that's out there, and I'm not talking, this is not Steve LeCroy standard, this is not Mercury Medical standard, this is American Heart, this is a European standard, Australian standard, even the recommendation from ACEP will tell you that you should be using lower volumes. And if you're not sure what the standard is now, instead of that 10 to 12, we're actually looking at somewhere between 5 and 7 or 6 or 7. So basically half the size that we once were giving volumes that I learned many years ago. So instead of using a bag that is this size, well, maybe a standard adult bag ought to be more to this size. And you can see the obvious comparison between the two. All the other parts are the same, that basically we took and made it a smaller bag. This is a 1,000 cc bag, basically has a stroke volume of around 750. It was interesting, several times this year I've been to some national conferences, both for paramedics and for respiratory therapists, and even one physician conference. And we hooked up a sophisticated test lung with a computer, big screen TV, and everybody could see how well you could actually manually ventilate. And I had about anywhere from 300 to 500 different people come by using a large adult bag hooked up to a nice test lung. And I can tell you, of the 300 to 400 people that actually went through the hands-on part of it, really not one person ventilated correctly. The volumes were too high. We end up with too much pressure. We cause a barotrauma. If we do that, we damage lung tissue. If we overstretch the lungs, we're using too much volume. We're causing what we call volutrauma. So people were doing that. Rates were off. And it was they were basically amazed. And I had everybody from brand new students all the way through licensed and skilled clinicians. But basically, most people couldn't do it right. And how often do you turn this very important part of a resuscitation over sometimes to your least trained person? So in the same experiment that I did at these shows, I took the big bag off and I put the smaller bag on, told each one of them, use the exact same technique that you always use or that you just use with the bigger bag. And almost 100% of those people were able to ventilate correctly. I said, use the same technique, don't change. And some did two hands, some did one hand, but the pressures and volumes were right in line with the standard. So it wasn't a huge change in technique, but it was a huge change in the impact on the patient. So it's pretty significant. Now, to look at what this bag offers, also offers a lot of value other than just being able to put air in and have air come out. As you can see here in front of me, this is a small adult bag. It's got a pressure manometer. Would you ever put that patient under pressure? It's like putting them under CPAP without a manometer, or putting them on any kind of positive pressure without a manometer. It is risky at best. I'd like to be able to document that pressures and see what I'm actually doing to the patient, because I want chest rise with the least amount of pressure that I can get. Now, I know under some circumstances you're going to have patients with stiff lungs, certain disease processes, and certain injuries. You may have to use higher pressures, but I'd like to be able to document that. It also comes with a pressure pop-off, which is rarely found on an adult bag. And the reason we put it on this particular bag, this bag can be used for pediatrics. So you're going to be able to potentially replace 2 bags with one if you have a space issue and something easier to work with that can use a variety of patients. Pops off at 40, or you can put the clip on, and if you have to get higher pressure to get chest rise, you can obviously be able to do that. I think this bag would be good down to about a 2-year-old or roughly 20 to 25 pound patient. Should be fine. I'm also believe that needs to be a skilled clinician doing this. This is not for just everybody, but a BVM should not be, this is not something you're going to see hang next to a fire extinguisher or an AED. This takes some skill to use. It is a BLS skill, but I don't think very few people are going to tell you it's an easy skill. The other thing that we also offer is a PEEP valve. PEEP valve would come on and off. A lot of times our bags will have a blue cap on the end, which is more of a deflector that any vomitus or the exhalation will go away from the user. But now we're seeing a lot of push and a lot of support research-wise to have a PEEP valve. When I first became an RT, that was kind of a big thing. Then we got away from it. Now it's come back. The advantage of using PEEP is to be able to recruit and then maintain and prevent the atelectasis that occurs, because that's going to interfere with oxygenation. That's going to interfere, obviously, with respiration and ventilation. I don't have to work to get those alveoli back once I have them open. And also, if you've placed an endotracheal tube, you bypass the patient's physiologic PEEP, which helps with that recruitment. So you really want to start out with at least 5. And I had one doctor in a cadaver lab say that if you're not using a PEEP valve, then you're probably doing it wrong. And of course, that's his opinion. But I think the research is really heading in that way, that the value of a PEEP valve cannot be underestimated of what you're getting with that. You can get that with a filter on it if you would like. It comes either way, however you'd like to do it. Another thing that comes up a lot of times in questions is, what if I put this on a patient who is still spontaneously breathing? You're doing a transport and you have it there in line. Maybe they've had some sedation type stuff. Can they breathe through it, or will they get some oxygen? Some people believe that because it has a duckbill type valve that they're not going to be able to breathe through it, nor are you going to get oxygen through it. Well, I can tell you that's not correct. Now, if the patient has to be able to overcome some resistance, and if you look at cross manufacturers, they should have in their literature, what is their inspiratory resistance of their bag, or how much work does a patient have to do to inhale? I can tell you ours is about 2.9 centimeters of water pressure, which is on the low end if you compare it to other manufacturers. So I think that's an important component. The other thing is that these bags should come with reservoirs. Ours comes on and off. You can get it either in a bag style reservoir, or you can get it in more of a corrugated tubing type reservoir. They both work about the same. Now, if you're going to take this bag, and I'm going to use it, the larger one, because it's a little bit more obvious, is we know that the rates in a cardiac arrest ventilation is going to be 10 a minute, 1 every 6 seconds. Now, I want you to watch how slow this bag is to recoil, and some people find this to be a negative. Some patients you might want to ventilate faster. Now, the reason it's slow is I don't have any O2 going to it, and I've got a bag that's empty, so I'm trying to pull a vacuum on an empty bag or a skinny tubing. So if you're going to ventilate somebody without a gas supply, you need to take the reservoir off. Now watch the recoil on the bag. It's the same as it would be for all bags. So remember, if you're pulling a vacuum, it would be an issue, and you wouldn't be able to do that. So quite a different components. You can get the mask, the bag with an adult mask. You can get it with child mask. You can get it configured with both masks. pretty straightforward however you would like to do it. And in my opinion, and I think I can support this with some research, the best manual ventilation that you can get is having a skilled clinician that really knows what they're doing. We're using an adult bag of at least 1,000 cc's. Now, we're trying to accomplish this ventilation to a majority of the adult population. You may have some extremes, some outliers, but that's going to be the same for everybody. And also having a manometer to know my pressures, having a PEEP valve to help with my recruitment, and then having a pop-off valve that's going to use it so I can use it a wider population. Now, as you look at different bags, now we call this a small adult. In the future, this might be just an adult bag. So if you look at bags, and they talk about children bags, they talk about pediatric bags, they talk about infant bags, I don't know if you realize that there is no consistency from manufacturer to manufacturer of what they call their bag. So instead of looking at the names, look at what they call the stroke volume. That's not how much water I can fill this up with water and get 1,000, but what's the volume on average I could get out of here if I wanted to? And so this one is going to be 750 cc's. So if you think about it, if you've got to make the math easier, if I've got a 220-pound patient and they're going to be 100 kilograms and it's 6 to 7, and I'm looking somewhere between 600 and 700 cc's per breath. Now, well within the range of a 1,000 cc's, but what if I was using this? Would it be more difficult to stay within that range? And I can tell you from the testing that I've done at those shows and those conferences, the answer is obviously that we're not very good at doing that. So again, it's a basic skill. It's not an easy skill, but the idea is to have good equipment, use the technology, and I think you'll see some better success and better outcomes with your respiratory arrest and your cardiac arrest patients. So if you have any questions, again, my name is Steve LeCroy. My email is SLeCroy, LECROY, @mercurymed.com. Have a good day and have a safe out there. Thank you.